So thank you very much. In the interest of time, I thought that I would get started while the slides are coming up. So next slide, please. So in principle, instead of reading the entire WHO report for Southern Africa, I thought I would try and take 2 or 3 additional themes to the discussion of treatment as prevention. And following a cabinet decision on the 29th of November 2003, which was really driven by actually Nelson Mandela, who the night before the cabinet in fact phoned every single one of the ministers up and said that they needed to vote their conscience and put an end to AIDS denialism. The initial treatment sites were all hospital-based and required central review and central approval. And it was only after the national costing model for HIV/AIDS in 2010 that actually looked at cost affordability, not only cost effectiveness, but how much could the country actually afford to provide treatment in South Africa, that in fact we got a large-scale rollout of HIV treatment by the WHO guidelines at 350 at the time, with a shift to primary health care, driven in part also by the CIPRA-SA study, which showed that nurses were not inferior to doctors in managing treatment. And it was the cost affordability, all the work that we had done up until then, looking at toxicity of D4T, at durability, at treatment switching, all of that information, including drug resistance, hepatitis B rates of 3.4% surface antigen positivity and 9% core antibody positivity. None of that had changed the guidelines. But when it came to demonstrating to government that in fact it was affordable to shift the guideline with an offset by moving treatment into primary health care, that was when we achieved it. So it was the health economists who actually changed the guidelines and not the scientists, not the prospective randomized controlled trial scientists. What has occurred, though, over 7 years of follow-up in the Thembalethu Clinic cohort is that we have not seen much of a shift between 2004 and 2010 in the treatment initiation CD4 count, the mean treatment initiation CD4 count. And that is really, in part, still driving our Department of Health to say, well, we've given you CD4 count 350, but you're not accessing those populations yet. And so why should we actually shift the treatment guidelines higher? The loss to follow-up rates have, although there was this year in 2009 where we had a healthcare workers' strike, that in fact did lead to a worsening loss to follow-up, but indeed the loss to follow-up remains below around 11% over this entire duration. What is interesting is that South Africans who give us their ID number in the ID book, there is only loss to follow-up of 4%. But in fact, those who do not have a much higher rate of loss to follow-up, approaching 25%, demonstrating that HIV is not a single country's problem. It is actually multiple countries and multiple regions that need to come together to actually exchange information about patients and have similar treatment guidelines. Over the total duration, so if one takes 8,172 person years, the total loss to follow-up is 25% over those 7 years, and about 16% have died. This is what it looks like graphically, though. The loss to follow-up is most common in the beginning. If we actually analyze the loss to follow-up rates and we go to the death registry in the National Department of Health, we find that 48% of people who've been lost have actually died. And if we look at the probability of HIV rebound or treatment failure. So this is an as-treated population for whom we have viral loads. There is a continuous line of treatment failure that goes out into the future, and first-line treatment will go to second-line treatment, and eventually second-line treatment will go to third-line treatment, unless we review which treatment regimen we would be giving as first-line treatment. So as the prevalence of NNRTI resistance increases, so we will need to change the first-line treatment regimen to accommodate it. The proportion switching, this is a 4-year graph, not a 7-year graph, shows that men are more likely to fail treatment than women. And that is in part because of missed clinic visits, because we don't make it easy for people working to actually participate in our treatment programs. We require them to come monthly for treatment regimens, particularly in stock-out situations, which does not accommodate their often increased work schedule, although not to say that women don't suffer a significant burden from coming to clinic on a monthly basis either. We know that CD4 count responses by baseline CD4 count are very similar in trend, and a similar increase over time. And actually, if we could initiate treatment earlier, we would have a more competent immune system to actually lead to full recovery. Whereas initiating later at low CD4 counts, there's less probability of a full immune recovery. We know that TB rates are exorbitantly high in low CD4 count patients. So these were screened. These were patients that were screened with symptoms, chest X-ray, and sputum diagnoses before gene expert, one must emphasize. But they were screened for tuberculosis and then initiated on antiretroviral therapy. Take a look at these rates, 21.7 per 100 patient years in patients presenting with a CD4 count less than 50. And although these drop on antiretroviral therapy, they are still almost double the background rates of tuberculosis in the country, and probably almost 100 times the rates in Diane Havlier's hometown in San Francisco. STRIDE study showed us that we should, in fact, the timing of initiating treatment, but are we actually succeeding in getting this message across to the National Treatment Program? And from our training and implementation work, we're probably only about a third of the way there to persuading Department of Health sites to actually follow the recommendations of STRIDE and other studies. So the costing model has really driven, and this is the second point I'd like to make, is that it's a repeat of the first point, or an emphasis of the first point, and that is that cost affordability will drive this question. When Gesine Meyer-Roth in our economics group led this piece of work, we looked at the old treatment guidelines based on CD4 count 200 with D4T and DDI in the regimens, as opposed to the new treatment guidelines at CD4 count 350 with tenofovir AZT to replace the or AZT 3TC in the second line, and abacavir for children, as opposed to the full WHO guidelines. The additional conditions that we put on this was that we needed to have a fixed price. So we actually had a reserve price for antiretroviral therapy in the last tender and said to folks, can you supply us at this price? We also said we wish to have fixed dose combinations and task shifting to nurses and pharmacy assistants. The whole piece was built on the transition probability on the Tembalete clinic cohort and the Herit-Sherzi pediatric cohort, with data that we'd collected on Therapy Edge over the entire time that the clinics have been available, and looked at 6-month transitions. Based the total number of patients initiating treatment out into the future, to 2016-17, was based on the ASSA model, and initiation rates for coverage were based on these transition probabilities. I'll try and speed up. So what was interesting is that over time we predicted that a certain proportion of patients would be switching to this new novel fixed dose combination regimen. And we showed again also that there would be a switch over time to the new regimen demonstrated in red. So some patients would continue to stay on the old blue regimen. What we showed was that the total number of patients increasing treatment over time, over these years, would almost double the number of patients on treatment out to 2016. The additional cost of the new treatment guideline, and with the task shifting taken into account, would only add 17%. And the reason for that is that patients actually, by delaying treatment by CD4 count, there's only a delay that occurs. It doesn't obviate treatment in its totality. So, as we said in the tea break, patients are going to be on treatment for 40 years. So what is the difference if we, between the old guideline and the new guideline would only probably be around 2 years. So seen over a long-term horizon, the additional cost is minimal. And then the full WHO guideline, which was not chosen for children, was an additional cost of 13%. I want to show the numbers in terms of total cost. So the new guideline led to a total cost of 70, this is in South African rands, so you could take a zero away, of $7 billion to the South African Department of Health. It is opposed, as opposed to the old treatment guideline of 59 billion rand, or $5 billion. So these numbers are staggering over a 5-year period of treatment. There is progress. So 2.7 million people on treatment, of 4.3 million that need to be treated by 2007. We've got very high HIV testing rates and TB testing offered to HIV testing offered to TB patients. PMTCD rates have come down. Our mortality rates we heard about earlier. Our drug pricing is low, but this is leading to total stockout worldwide because the chemical manufacturers are unable to actually keep up with the supply, the demand that for tenofovir that is being created in South Africa. And key populations remains a focus. And one of the emphasis that we have in South Africa that is significant, a significant story, is the question of stockout. And here we have, in a survey of clinics, we have 53% of clinics in one province reporting regular stockout. So this may lead to resistance with very much with similar resistance patterns as shown earlier, both for NRTI and NNRTI. The solution that we are considering for the stock outages is our technologic solutions. So can we actually automate pharmacies? Can we actually bring in, reduce patient waiting times, improve adherence, and reduce the cost of dispensing while improving stock management into a predictive stock management method? Potentially also allowing patients to move between sites and collect their medicines where they are. So if they are migrant or perhaps wish to collect their medicines one time close to the work and another time close to their home, that we can actually make this possible. It may also enable us to actually dispense medicines away from the healthcare facility, reducing the overwhelming burden of HIV to these healthcare facilities. I'll stop there, and I've run over. I've probably been the naughtiest of all of the speakers. Thank you very much.